Good morning, everyone, and welcome to the Advanced Methods webinar series. My name is Anne Greenwood. I'm the Education Training Lead for Population Data BC, and it's my pleasure to introduce Dr. Mahyar Etminan, who will be presenting on use of causal diagrams and variable selection for causal observational studies. Dr. Etminan is a pharmacoepidemiologist and associate professor in the Department of Ophthalmology with an appointment in the Departments of Medicine, Division of Neurology at the University of British Columbia. His areas of research are focused in ocular epidemiology and drug safety using large population-based databases. In recent years, he has taken a keen interest in the use of causal diagrams in the design and evaluation of epidemiologic studies that address a causal question and has a number of publications in this area in the journals of CHEST, British Medical Journal, and Gastroenterology. So thank you everyone for attending. Thanks again, Dr. Etminan, for presenting today, and I'll pass it over to you, Dr. Etminan.
Thank you, Anne. Thanks everyone for joining us today. I'd like to start with some a discussion of the differences between RCTs and observational studies. So a lot of us who are involved in epidemiological research, we know that RCTs have the advantage of minimizing bias because of randomization and blinding. And observational studies lack randomization and usually blinding. And that puts these types of studies into a disadvantage in that they are more prone to different types of biases. Mainly, perhaps the most important one would be confounding, selection bias, and also measurement error, which can affect both the outcome, the exposure, or the covariates of interest. So before talking about causal diagrams, let's just think about why they could be helpful, and what if we actually could have a visual for the type of biases that we want to deal with. And this is very similar to, say, a plumber who is dealing with a leak in a house and looks at the plumbing plan or blueprint for that house to try to find where that leak is. It would be great if, as researchers, we also had access to that sort of a blueprint, so we could identify the type of biases that we may deal with in our research studies, or the type of biases that we may encounter in studies that we are reading or critiquing for different purposes. And so that brings me to the idea of causal diagrams, or more specifically referred to as causal directed acyclic graphs, or CDAGs. And these actually have been around for a few years, and they have been used extensively in different areas, mainly in computer science, in writing algorithms, and have been mathematically proven. There's mathematical proofs available that they do work. And it was actually Judea Pearl, who is a computer scientist at UCLA, who thought of adapting causal diagrams to medical research. And they have been quite popular in the last few years for this purpose as well. Let's just go briefly on how these diagrams work. There's a lot of literature out there that you can read if you want more specifics on causal diagrams and how they function. And I will also provide you with a few at the end of the presentation. But basically, these are diagrams that are made up of nodes and arrows. And the nodes are mainly the variables of interest. And the arrows point to the direction, the causal direction of these variables. So more specifically, again, you have these variables that are nodes with arrows. They are acyclic, so one variable cannot cause itself. And you have paths between the variables and the arrows. I have also here listed 3 different types of causal diagrams that resemble specific structures that we will also review later on. One is a collider, which is a variable that is a common effect of 2 other variables. So Z here is a common effect of X and Y. Because as the name sort of implies, the 2 variables are colliding onto Z. And the other is a confounder, which is a common cause structure. So Z is a common cause of X and Y. We also have what we call a mediator. Here Z is a mediator between X and Y at the bottom. So basically what it means is that a portion of the effect of X on Y is mediated through Z. So we call Z a mediator, and we'll talk about mediators later on. So think about these sort of nodes and arrows as paths. So you have X and Y is an open path. So again, think of information flowing when you have an open path. When you have a path that's blocked, that information is no longer flowing. So the information from X and Y is blocked by Z. We can also block paths through conditioning. And so that's something that we can do ourselves. So we can block the flow of information from X to Y through different types of conditioning. And conditioning is a very common sort of a tool in epidemiology, which basically means that holding a variable to a subset of its values. And there are different types of conditionings that we use. For example, matching that many of you may have heard of is a type of conditioning where we match different variables, usually because of controlling for confounding. For example, we can match in case control studies cases and controls by age. Stratification is another form of conditioning where we stratify data depending on the variable that we are interested in. Restriction is probably the simplest form of conditioning where we only look at a subset of the data or the population in our study. For example, we only want to restrict our data analysis to, say, men versus women. That's also a form of conditioning. But probably the most commonly used type of statistical conditioning is statistical adjustment, simply because it's more flexible and it doesn't have the limitations of some of the other methods that we just talked about. So 2 important sort of rules that you may want to remember here is that we can block paths by conditioning for variables that are non-colliders. So those would be confounders, and we'll talk about that very soon. And we can unblock paths by conditioning on colliders. So we can block paths if they're non-collider variables, but we actually can unblock them when we condition on collider variables. So here is a very simple sort of a description of stratification. We have some global data of disease versus an exposure, say, smoking. And when we look at the global data, we find a relative risk of 1.06, no effect. And when we stratify by age, we actually find different results. So this is an example of stratification by age to control for confounding. So let's talk about confounding. Confounding is, again, probably the most challenging and most prevalent type of bias that we deal with in observational studies. And let's think about it, maybe a non-medical example first to show exactly what confounding is and what it does. So many drivers, especially in a rainy city like Vancouver, who are involved in car accidents may happen to also have an umbrella with them. And so some people may say, well, do do umbrellas cause car accidents? And of course, the answer is no. And if you see in my DAG, there is really no arrow from umbrella and car accidents. But if you disregard the confounding effect of rainy weather, which is a common cause of umbrella use and car accidents, you may actually see a biased or a confounded effect of umbrellas on car accidents. So again, a biased association because of the confounding effect of rainy weather. And if we condition for rainy weather through the different conditioning techniques that we talked about, that association should go away because, again, we are controlling for a confounder here. So this is the simplest sort of a non-medical description of what confounding can do. Let's look at a more sort of a clinical scenario. So you have a physician is wondering why he's seeing more cases of GI bleed with a new acid blocker. And he's especially baffled because the acid blocker in randomized trials actually has not shown to have an increase in risk of GI bleeds compared to the older drug. But in clinical practice, he's seeing a lot of GI bleeds and he's wondering why that is. So this is a situation, again, it's a type of confounding that we specifically refer to as confounding by disease severity, or also sometimes referred to as channeling bias. And that is when, in this case, this new acid blocker is channeled or prescribed to patients who have a higher baseline risk of GI bleeding. And this higher GI severity is acting as a confounder. And so if we don't control for this GI severity or GERD, gastrointestinal reflux disease, this confounded effect would look like the drug is actually causing the bleeding, where in fact it's a confounding by disease severity situation. So again, if we were to do a study, we have to control for severe GERD to prevent any sort of confounding by disease severity. Here's another example of a study where they looked at androgen deprivation. These are drugs, they're hormones used for prostate cancer. And in this study, men who had used these drugs, they were shown to have a higher risk of Alzheimer's disease. And this study actually had not controlled for a cognitive status, which again is a common cause or a confounder between ADT use and Alzheimer's disease, because cognitive status can affect ADD prescribing. And we know it's a definite risk factor for Alzheimer's disease as well. So lack of adjustment or conditioning by this confounding variable can produce potentially biased results. So confounding actually can present itself in different shapes and forms. One other form that again sort of appears a lot in observational studies is what we call healthy user effect or healthy user bias. And this is a bias where patients in these observational studies, again, it does occur in a lot of diet and cancer studies, because they are healthier and are involved in healthier lifestyles, perhaps they exercise more or they have a better diet, they tend to have a lower risk of developing the outcome, making it look like that it's the actual drug that's showing this benefit. In this study that where this bias could have happened, it is a case-controlled study that looked at statin drugs, popular medications for cholesterol lowering. where it showed that the relative odds, the relative reduction in odds is around 62%. So the odds ratio of 0.38. So a profound benefit of statin use in terms of prostate cancer. So again, one potential scenario could be that this study could have been affected by healthy user bias. And we can draw a DAG for that. So we have statins with an arrow to prostate cancer, a dotted arrow, meaning that we don't really know if statins cause prostate cancer. That's the question. So we have U, a healthy behavior, which is an unmeasured confounder that we usually can't really measure in our studies. And there's an arrow from U to MD visits, because these patients are usually more health conscious and visit their physicians more often. And once they visit their physician more often, they're more likely to get a statin. So you have a DAG, a structure of a DAG that looks like this. And so we can see here how the confounding can occur. What we call here is when we have a backdoor path through U and MD visits to prostate cancer. So potentially making it look like that statins are preventing prostate cancer, when in fact it could be due to this bias. And so we can adjust for this. And again, this causal diagram can inform us on which variables to adjust for. Generally, we don't have U measured, but we do have, usually we have data on the number of MD visits. So theoretically, we can adjust for U, which we don't have, but we can also adjust for MD visits to block this confounding or biasing path for this study. So again, here's another example where a causal diagram can inform us on the causal sort of a situation for the question and help us identify the variables that need to be adjusted for. Protopathic bias, also referred to as reverse causality, is another type of bias that happens in pharmacoepidemiological studies. Now, one interesting question that sort of came out a few years ago, that where protopathic bias could have played a role in, was the question of whether acetaminophen, a very popular over-the-counter medication, can actually increase the risk of asthma. And so there were different studies suggesting, some suggesting that there is a risk and others that there isn't. And so protopathic bias could have been potentially one reason for the studies that did show an increase in risk. And again, here is the causal diagram. So we know that viral infections are potentially or are risk factors for asthma. And when you have a viral infection, you can get a fever, and that fever can lead to use of acetaminophen. So again, you have a backdoor path that can create this biasing path through fever and viral infection to asthma. And adjusting for either fever or viral infection here in this study would control for this bias for this specific question. Here is just to show you that there are a lot of studies can have this protopathic bias situation. For example, a number of studies have shown that proton pump inhibitors, again, which are acid blockers, can increase the risk of stomach cancer. Now, if proton pump inhibitor use was measured around the time of when the stomach cancer was sort of presenting itself, again, this could be a reverse causation situation where the drug was used early on to control the symptom of the disease. Similarly, again, with anti-diabetic drugs and pancreatic cancer, pancreatic cancer, it could cause hyperglycemia, increased glucose levels a few weeks, let's say, before the patient is diagnosed, prompting patients to be on this drug to control the symptom, making it look like the drug is causing pancreatic cancer. So I would probably say that after confounding, selection bias is probably the most important or prevalent sort of a bias that we deal with in observational studies. And this is what I call the man-made problem, because it's a bias that the investigators actually create. Whereas when we talk about confounding, it's something that is not under our control. We are given data sets that may have and let's look at exactly what happened. So remember, we talked about colliders. A collider is a common effect of two other variables. Unlike a confounder where conditioning is actually needed to block the path, conditioning on a collider opens the path. And so I think this was one of the two sort of cardinal rules that we talked about earlier. Conditioning on a non-collider variable blocks a path, but if you condition on a collider, you actually open the path. And when you open the path, it's like opening a can of worms. You may create different types of biases in your data set. So let's look at one example. So you have a cohort study of men that's examining the risk of erectile dysfunction and prostate cancer, and no association is found. But when investigators actually stratify the data by the number of urologist visits, an unexpected association is found, and we want to know exactly what's going on. So if we draw the simple DAG, so you have erectile dysfunction with an arrow going to urologist visits, because we know men with ED visit urologists more often, and again, men with prostate cancer also visit urologists more often. But there is really no arrow between ED and prostate cancer. However, when we condition on urologist visits, we are opening a new path because we're conditioning on a collider. So ED and prostate cancer become associated. And the reason for that is that when we know a man is, for example, a man has prostate cancer and has visited a urologist, it's easier to sort of guess that they also may have or may not have ED, and they become correlated that way. So what we call the collider bias, collider stratification bias, or in sort of epi terms, selection bias has occurred when we have stratified our analysis by urologist visits. Here's another sort of a selection bias scenario that can happen in hospital sort of studies, hospital case control studies where controls are selected from the hospital. And this DAG is trying to answer the question whether fluoroquinolone antibiotics increase the risk of epilepsy. And fluoroquinolones are very popular antibiotics. They have shown to have central nervous system side effects, and epilepsy was one of them. And so let's say an investigator wants to answer this question using hospital data. So we have a DAG here where we have two variables, pneumonia and electrolyte imbalance. So you have pneumonia, which is a cause of fluoroquinolone use and hospitalization, and electrolyte imbalance, which is also a common cause of hospitalization and epilepsy. So you can see that there is really no sort of an open path between fluoroquinolones and epilepsy, because any path that there could have been is blocked by hospitalization. Now, when we condition on hospitalization, so for example, select our controls from the hospital, this path that is blocked is open, and what we now have is, again, a collider bias or a selection bias situation. That's also sometimes referred to as Bergson's paradox. And this new path now associates fluoroquinolone use to epilepsy, which again, through a biased, spurious path, fluoroquinolone use becomes associated with epilepsy, which and again, this happens because of the condition by hospitalization, whereas before we had before condition and hospitalization, there was no association because the path was blocked. Now, it's sort of interesting to kind of go back and review the definition of a confounder in a lot of perhaps the older epidemiology textbooks, which usually said something like a variable that's associated with both the outcome and the exposure. So if you want to look at that, if you look at hospitalization here, it does actually fit that definition. So hospitalization is associated with fluoroquinolone use through pneumonia and also with epilepsy through electrolyte imbalance. So if we wanted to go with the older definition of confounding, a confounder, which is still is used in some websites or even the older books, hospitalization would be a confounder here, and it should have been adjusted for. But we just saw, adjusting for hospitalization can actually introduce bias. So this is one of these situations where the older definition of a confounder can actually happen to be a collider, and how drawing these causal diagrams can help us assist us in better understanding of exactly what my variable is. Is it a confounder? Is it a collider? And whether I should be controlling for it. So let's talk about overadjustment bias. So we saw earlier on the structure of a mediator. Let's talk again about the question of statins and MI. So we know statins lower the risk of MIs or heart attacks, and they can do this obviously through cholesterol reduction, which we call the indirect effect. But we also know that statins can also lower heart attacks through non-cholesterol lowering mechanisms, antioxidative properties or potentially other properties, and we call that the direct effect. So the direct effect and the indirect effect of statins is what we call the total effect, and that's what we are usually looking for when we are looking at effects or effectiveness or adverse events of drugs. We're looking at the total effect. Now, if that is the actual objective of looking at the total effect of statins, then adjusting for cholesterol, which is a mediator, actually creates a bias, and it actually underestimates the total effect of statins on MI. So because we usually want to look at the total effect of drugs, and in this case statins, then adjusting for a mediator will lead to a biased estimates, or also called overadjustment bias. So something that we should not be doing. Now, the question arises as to how do you know a variable can be a mediator or a confounder? And again, the causal diagram can show this by telling us, in terms of the temporality of the variable. So let's say if you're looking at a trial of statins and heart attacks, and you're measuring cholesterol levels every month in that trial, well, that would fit a mediator situation, because you're measuring cholesterols after statin use. And so you have a mediator, and again, if you're looking at the total effect of statins, cholesterol should not be adjusted for. However, if you're looking at the risk of statins and MIs, and you don't have any cholesterol data, which is usually the case with administrative databases, and you still want to look at cholesterol. Actually, let's say you do have cholesterol data, but it's not measured after statin use. You have cholesterol data before statin use, or you just simply want to adjust for cholesterol levels as a confounder. So in this case, controlling for cholesterol before statin use is actually controlling for this variable as a confounder, because you're not adjusting for it as a mediator, because it's not happening after statin use, it's happening before statin use. So a variable can act as a confounder or a mediator depending on its temporality, and causal diagrams can give us a better picture of what those are. So generally speaking, the cardinal rules of causal assessment is that we have this open path between an exposure and outcome that we want to measure, and we want to keep that path open because that's our major objective. And then we want to block any other biasing path in our causal question or any of the shared causes. Again, because we don't want to create any bias, we want to block all the biasing paths in our analysis, and certainly we don't want to open a new biasing path in terms of a collider variable. So we do not want to condition on a collider variable. And again, if the question is, if the question we're trying to answer is the total effect of that intervention with respect to the outcome, we don't want to be adjusting for a mediator as well. So this is just the sort of the crux of what we want to aim at when we are answering a causal question. So here, sort of follow up to that discussion. Let's talk about the different variables and their roles in a causal question. So here we have an exposure and an outcome, y. X1 is a mediator, is a typical mediator variable that, again, we should not adjust for. X2 is a effect of the outcome, and sometimes it's actually called a virtual collider. Because if you have an unmeasured variable, it can act as a collider. So it doesn't have your typical collider common effect structure, but it can act as a collider if you condition on it. So, and again, intuitively, it doesn't really make sense of why would you want to adjust for an effect of the outcome. X3 is a typical collider that we should not adjust for. X4 is a cause of the exposure, and again, causes of exposures we don't really care much about. X5 is an effect of an exposure that is not a mediator. So there is really no arrow from X5 to Y. It's just the effect of the exposure. Again, there's no need to adjust for that. X7 is a risk factor. So risk factors are a bit interesting. So, if you want to think about it in very pure terms, risk factors should not be adjusted for because, again, it's not a confounder. But we have some data that suggests that they may increase the precision around the estimate. And sometimes we don't really know if the risk factor is a pure risk factor. It's very hard to say, or whether there is a potential for association with the exposure, and that's what we call chance confounders. So if that is the case, then risk factors can be adjusted for. Certainly, it is not a big no-no like conditioning or adjusting for a collider, but it is a bit of a sort of an interesting both sides of a argument, sort of a discussion in terms of adjusting for risk factors. So we've talked about relatively more simple time fixed scenarios. This can get quite complex when you have a time dependent confounder, especially time dependent confounders that are affected by previous exposures. And again, let's look at the statin example. So you have E0, which is a baseline statin use. And that is, there's an arrow from E0 to C1, which is, let's say, cholesterol levels at C1, which then again leads to a change in exposure at E1. So let's say you have the statins at baseline, and there is a reduction in cholesterol, so that the physician decides that you no longer need to be a statin. So the exposure status changes to 0. And so this can actually continue with, E0, C1, E1, C2, and so on. But I just sort of wanted to show you this without the complexities as to what's going on. So, and you have, of course, U, which is, say, an unmeasured variable BMI. So if we adjust or condition using the traditional techniques that we've talked about, two things will happen. The first is that you have, again, C1 is a mediator between E0 and D2. So you're adjusting for a mediator, which is not something we want to do. And also through U, the adjustment or conditioning of C1 is causing, again, a collider bias situation. So we would be biasing our study if we use the traditional approaches for adjustment when you have a time-dependent confounder that's affected by previous exposure. And what is recommended in each situation is what we call G methods or causal methods that do not sort of function on conditioning for these variables. And so they do not have the issues that we just talked about. And those are, then again, you can read more about these, are inverse probability of treatment weighting, the parametric G formula, and G estimation. These are all sort of different G method techniques that have their advantages and disadvantages that can be used when you have a time-dependent confounder that can actually act as a mediator as well. Just also a quick sort of review on some limitation of statistical approaches for confounding confounder identification. So these would be the sort of automated statistical procedures like stepwise regression. Now, these techniques are mostly built for prediction modeling, and so that's why they're sort of not ideal, or perhaps not at all ideal. In fact, if you want, for example, identify a variable to see whether it's a confounder or not. Again, they use the p-value approach to identify a confounder by seeing how that variable is predicting the outcome. But again, we know that a confounder is a common cause variable that's associated with, in most times, situations with the outcome and the exposure. So again, the p-value approach is not recommended to select confounders. The other commonly cited approach is what we call a 10% rule. So if there is a change in the effect size in a model by 10%, of a variable, then that kind of demonstrates presence of confounding. And again, that is also not recommended because just even through this talk and the examples that we saw, you could have selection bias and a change in the effect size through selection bias or overadjustment bias. So just because there is a change in effect size doesn't necessarily mean that that variable is a confounder. So again, these techniques are sort of built for prediction modeling, not really for causal questions. This is a study that looked at statin use and long-related mortality. I just wanted to show you that when you're doing your own studies or real-life studies, things can get actually quite complex. And this is not the complete DAG for this study. I've cut out a lot of the variables again just to alleviate some of the complexities. For example, obviously age is a confounding variable that's not here, but the boxes around the variables are the variables that were adjusted for in this study, and the ones, some of the ones that I've added on, like smoking, are variables that were not adjusted for in the study or mentioned. That again, a causal diagram should have those variables in them as well, even if the variable is not included or contained in a data set. The causal diagram should have all the shared causes for that question. So smoking, for example, so heart disease, for example, is a relatively simple, simple in that it is quite evident that it is a confounder because it's a very simple common cause situation. But smoking is perhaps less evident because you do have an arrow to lung mortality, but you have an arrow through heart disease to statin. So it's still a confounder, and should, that path should be blocked, just to kind of show you that these things can get complex, and the confounding paths can also get quite challenging, and you're not always going to have the very simple sort of a common cause structure. Let's see. Okay, so just to wrap up, talk about some of the strengths of the DAG. So obviously, again, a better visual of the type of biases that we are dealing with, specifically confounding, and variables that we should not be conditioning on. And again, just like the example we saw with healthy patient bias, where we didn't have information on healthy lifestyles, but we had information on the number of MD visits, that we could use that to block the biasing path. I mean, that is something I think that's very instrumental for researchers to know, to better control for confounding with the aid of a causal diagram. And again, not just for research, but any study that you're doing, if you draw a causal diagram for that question, it would help you understand exactly what the study did and whether there are any variables that should have been adjusted for, or if in the design there was any sort of a selection bias that's going on. Of course, there are limitations as well. An accurate DAG should have all the shared causes for that question, and sometimes we simply just don't have enough information about a specific question to know whether a variable is a confounder or plays any role on the causal diagram. Sometimes we really don't know the relation between two variables. Did A cause B, or is the arrow the other way around? Did B caused A? And what's recommended sometimes is to sort of have, just like we have sensitivity analyses, using statistical techniques, we can have different DAG scenarios as a sensitivity analysis, and just to see what results we get with the different DAG situations. And also the fact that they can't really show us the magnitude or the direction of a bias, simply that the bias could occur, in a study. Some references. So the CHEST article that's freely available has more detail on what I covered today and maybe more examples. And also in terms of adjustments, there's also a paper in the American Heart Journal that we did. And also the book by Miguel Hernan is a very, very good tool and a resource for a more detailed discussion of causal diagrams and bias. Okay, so I'm happy to answer any questions.
Great. Thank you very much for an excellent presentation. Really very helpful, and all the diagrams, I think, give a good example of context for different work. So thank you for that. First question is, how can you describe effect modifications with DAGs?
That's a good question. So effect modification is actually it's relatively simple, but it does get complicated. So in the most simple way is just one arrow to just an arrow from a variable that you think is the effect modifier to the outcome, because there's no second arrow from the variable to the exposure. So it actually looks like in the most simplest way, it looks like a risk factor, because simply you are trying to see whether there is an effect, if the effect is different, within a subgroup of let's say, men versus women or different age groups.
So 2 questions. Current official death number from COVID-19 is around 500,000. How to identify the treatment-caused death? For example, a ventilator or drugs have caused mortality, but it was attributed to COVID.
So is the question how can we use causal diagrams to see whether the cause of death was from COVID versus other variables? Is that?
Yes, that's the question. Yeah. Thank you for your question.
That's actually a very good question. And, with COVID sort of in the news, I have been thinking about it myself as well. So, in a perfect situation, again, I think I go back to the cardinal rules that I talked about, where if we have a causal question, does COVID cause death? Then we have to block all the other potential causes of COVID and death, so confounders. If we can block all those other possibilities, then the only possibility would be death due to COVID. But again, it becomes complex, because a lot of the risk factors or confounders that we have could also have some sort of an association with COVID, and there's also the temporality of the timing of when COVID happened. So I think that's a tough question, but I think that the causal diagrams can definitely help us being better informed, and whether they can actually answer the question, I'm not sure.
Okay, thank you. We have another question. What is exactly meant by adjustment and by observational studies? You mean data obtained from hospital data? What about sample surveys of the general public?
So observational studies, we mean studies that are not randomized trials. So the exposure could have been affected by a whole host of different variables, and that could that could be registry studies, that could be surveys where you haven't really randomized the exposure to balance for the potential confounding variables, the benefit, the strength of RCTs. that is not the situation that we have in other types of, or non-experimental studies, if you will. Adjustment, again, it's a form of statistical conditioning. Perhaps in simpler terms, is that you want to make sure that the group that is using the intervention or the drug and that the group that is not are equal by the different important confounding variables. So when we adjust for them, we try to make them equal so that there is no more confounding between the two groups.
Okay, thank you. Next question. Is there a way to justify the validity of a certain DAG or any approaches to avoid the consequences if the DAG is wrong?
That's a good question. Again, knowledge of that specific topic definitely helps, making sure that you have all the shared causes, whether they're measured or unmeasured. And also what's being suggested is to come up with 2 or 3 different DAGs. So you think that, for example, you have a bunch of variables and they're connected in a certain way, but you think that some of these variables could also have a different connection. So you have a second DAG and a third DAG, and then you can analyze your data based on these 3 different DAGs and just look at the results and see if they change or why they change.
Great, thank you. Next question. Could you recommend any source where analysis using DAG is performed?
Yes, so actually, Miguel Hernan has an excellent lecture that he gives through the EDX, which is, I believe, the online Harvard courses. If you just Google Miguel Hernan Causal Diagrams EDX, it's a free course that you can register and learn more about DAGs. And I believe that he has questions after, at the end of each lecture. And if you get 70% on those questions, and believe me, they're not easy, you get a certificate for that course as well. So I would definitely recommend that, because his book for, if you just sort of want to start introductory, his book is good, but there may be areas that are a bit more complex. But I think that online course is very helpful.
Great, thank you. That's an excellent suggestion, and maybe we can get a link to that at the end. So this was a part 2 question from Key. So to increase mental illnesses in the last year has also been attributed to COVID. Increased mental illness in the last year has also been attributed to COVID. Many of them were caused by lockdown and other restrictions. How do we separate the policy response from COVID?
Again, if you know of all causes of mental illnesses, and so your outcome is mental illness, and what was the intervention? Is it?
It says increase of mental illness in the last year was attributed to COVID. Many of them were caused by lockdown and other restrictions.
Right. So if you draw causal diagrams of all shared causes of COVID and mental illnesses, right? I think that would definitely give you at least a picture of what other confounders are there for this question, and which one do you think is, in terms of the timing of which one happened first, may have contributed to COVID. So I think the DAG would definitely help answer some of the questions.
Next question. How do you approach choosing which variables to include in a DAG?
So the DAG should have all variables that are shared causes, so confounders basically. all variables that you think could be potential mediators, and any other variable that you or your colleagues think that should be sort of looked at or adjusted for should be, using a DAG, you should kind of see whether you need to adjust for that or not. So definitely all shared causes should be included in the DAG, because again, our question is, we have this causal path, which is the question we want to answer, and then you have to have all the other biasing paths, all the other shared causes to sort of control for or block, so that the only open path at the end of the day is the path that you're trying to answer. So definitely all shared causes. Any variable that you think is important should be looked at as to see whether it should be included or not. Definitely mediators should be included, just to see whether you want to avoid adjusting for them, or you want to do more advanced mediation analysis, as we call, to look at the effect of the mediator. So so I would say that definitely all shared causes should be included.
Great. Thank you very much for all the wealth of questions and answers that have been provided here. I think that's the end of our Q&A session. Thank you again, everyone, for attending. Thanks, Dr. Epmion, for being part of this presentation and sharing a wealth of information for everyone.
Thank you.
All right.
Thanks for the invitation.
Thank you. Bye now.
Bye-bye.